everybody. It is a pleasure to be here, and especially to follow in the footsteps of Sharon and Adele. We are going to talk now about a project that ran in the Trust for 3 years, funded by the Research for Patient Benefits, which focused on shared decision-making in the context of psychiatric medication management, where we offered training to service users, psychiatrists, and care coordinators related to the then pathway of rehabilitation and recovery in parallel. We took a participatory approach for all of our activities from the bid stage. We involved service users as equals, as co-leads, as managers, and as trainers and researchers. The impact of the training was evaluated at pre-program stage, immediately after the training, and a follow-up 12 months later. I just want to summarize the key findings because we haven't got enough time. The primary outcome was the reduction of decisional conflict about medication, and this has been significantly achieved by the service users. Feeling more informed and being clearer about what was important to them in terms of medication was also achieved. Most of the service users felt that psychiatrists encourage more decisional involvement following the program. These were results to do with the option scale. We had no changes in attitudes to medication, and the intervention was cost-effective for 40% of the sample, as evaluated by Professor Paul McCrone from the Institute of Psychiatry. Following the end of the project, we wanted to implement it and to try and embed it as an innovation. The focus on implementation or translational impact is very clear in the requirements of the NHS and the National Institute of Health Research. And the NPT, which stands for the Normalization Process Theory, is a new attempt for the last 10 years, not so new, to really develop a sociological approach to identify and understand what happens when we try to embed an innovation, what could be the facilitators and the barriers, some that we can predict in advance and some we cannot. So it's really in this, with this intention that we embarked on the implementation. And the main key steps where Mary Jane is one of the main actors in the trust on this particular project, was to ensure that shared decision-making will become trust policy. We have been successful in that, and there are many people I could thank for this particular success, including Aidan. Mary Jane developed also an inviting leaflet, which is widely distributed to people who use services. She also meets teams to introduce the shared decision-making, individual teams, and we are providing training to new groups. We have already started by providing training to peer support workers. We hope to do it to another cohort, as well as to do it with the non-medical prescribers. We have tried to introduce knowledge about alternatives to medication. We have done already a conference on hearing voices that led in a very short time, because of the interest of the participant at the conference, to the commissioning by the trust of 2 groups that will run in the voluntary sector, in Lifecraft and in Mind, in Cambridge and Peterborough, by both service users and some of the psychologists with a great interest in that. We are now part of the PROMISE initiative, and we will speak more about that. And obviously we have publication and conference presentations. I will speak about one attempt, if you want, to close the gap in terms of embedding an innovation. And these are personalized summary letters. It's really one implementation step. Current letters from clinician to service users are brief, administrative in tone. They are written about the person, but addressed to another provider. And the person gets a copy of it. The person has little say in the content of the letter. And we thought that such letters at the moment reflect the distance between the person and the clinician. So instead, we would like to move to personal letters instead of having forms and what is happening right now, where the personal letters will signify summary of a shared activity, jointly agreed decisions about medication, agree to disagree, agree a compromise, agree what the clinician needs to do, what the person needs to do, and what involved others need to do. The impact of such letter, hopefully, will be to highlight the contribution by the person to the shared decisions and to the action that these lead to demonstrate to the person that she or he and their views are respected by the clinician, encourage further taking responsibility by all of those involved, including the person, and to foster the development of trusting relationship. Mary Jane is now taking over.
So one thing that we were very clear with these letters is that these letters will be CC'd to the person's GP, but they are written to the service user themselves. We can't be writing two separate letters and making more work for ourselves. So they're going to be doing two jobs: communicating with the patient, summarising that discussion, but at the same time letting the GP know what's been agreed in a clear way. What might they look like? A space for individual differences, so being very open with people that you might not have reached agreement, but that happens a lot, and just being clear about that and acknowledging that in a very open way. A place to take account of what is important for the service user, so validating what they're saying and trying to strengthen that relationship by showing people that you have really heard. We've had various discussions about should diagnosis be in the letter. Some service users have said to me, I don't like opening a letter and seeing at the top of it, diagnosis. That kind of seems to label me and maybe belittles what the rest of the letter says. So we can think about, yes, there is a use to diagnosis being in the letter. It's on our RIO system. Why shouldn't it be on the letter to the service user? But where's it best put? The top of the letter? The bottom of the letter? Should there be some narrative about it? You should have discussed the diagnosis in the outpatient appointment, and maybe some narrative about whether you agreed or didn't agree about that diagnosis. Issues in describing service users' emotions and frustration, how personal these letters should be. Obviously, it's going to vary from service user to service user and depends on the relationship you've had with them, but they're all things to think about. We'd hope that when the service user gets the letter, you've already said to them, please feel free to comment on the content of it. Tell us what we think we've got right, tell us what you think we haven't got right here, so that we can just get better understanding. It's a means of communication in both ways. Hopefully it'll be time-saving, because when that person sees you next time, they've got in writing what you discussed last time, and that's kind of a springboard for your next discussion. In years to come, maybe another step could be writing letters jointly with appropriate technology. It's something we have in the back of our minds. And obviously this aspect of writing things jointly, we're doing with care plans already, and we want to develop that further. Thank you.